As you settle into this moment, wherever you find yourself, take notice of the gentle rhythm within you. Your heart beats without instruction. Your lungs expand and release, and beneath the surface of your awareness, countless processes unfold with quiet precision. Tonight, we journey into the landscape of pathology, not as a catalog of fears, but as an exploration of how the body responds when its harmony shifts. This is the science of understanding what happens when systems drift from their typical patterns, and within that understanding lies a profound appreciation for the resilience built into every cell. Pathology is often described as the study of disease, but this simple definition barely touches the richness of what we're truly examining. Think of it instead as the biography of disruption, the story of how bodies respond to challenges that range from the molecular to the systemic. Every symptom, every change in tissue, every laboratory value that deviates from expected ranges tells us something about the conversation happening between threat and response, between damage and repair. We are not here to memorize lists of afflictions, but to understand the mechanisms, the why and how behind the changes that occur when life encounters obstacles. The word pathology itself comes from the Greek pathos, meaning suffering or disease, and logos, meaning study. Yet what we discover in this field is not merely suffering, but adaptation, not just breakdown, but the body's continuous attempts at restoration. When we examine diseased tissue under a microscope, we see evidence of battles fought at the cellular level, of immune cells migrating to sites of injury, of tissues attempting to wall off damage or regenerate what has been lost. Pathology reveals the body as an active participant in its own story, not a passive victim of circumstance. To understand disease mechanisms, we begin with a fundamental truth about the human body. It exists in a state called homeostasis, a dynamic equilibrium where thousands of variables remain within relatively narrow ranges despite constant external and internal changes. Your body temperature hovers near 37 degrees Celsius. Your blood glucose levels rise and fall within predictable boundaries after meals. Your blood pressure adjusts moment to moment as you stand or sit or climb stairs. This is not static balance, but responsive stability, achieved through feedback loops, hormonal signals, nervous system adjustments, and cellular communications that occur without conscious thought. Disease, in the broadest sense, represents a departure from this homeostatic state, but the departure is rarely abrupt or random. Instead, imagine homeostasis as a river flowing through a well-worn channel. The water follows familiar patterns, eddies in expected places, maintains a certain depth and speed. Disease is what happens when something alters that channel, when a boulder falls and diverts the current, when the water level rises or falls beyond usual ranges, when the river seeks a new course. The body's response to these changes, the way it attempts to accommodate or correct them, creates the signs and symptoms we recognize as illness. Within the study of pathology, we recognize two major divisions that help organize our understanding. General pathology examines the fundamental processes that underlie disease across all organ systems. These are the common mechanisms, the shared patterns of cellular injury, inflammation, healing, and growth disturbance that apply whether we're looking at liver tissue or lung tissue, heart muscle or kidney tubules. Systemic pathology, in contrast, focuses on specific organ systems, examining how these general principles manifest in particular tissues with their unique structures and functions. Tonight, our focus rests primarily within general pathology, where we build the foundation that makes all subsequent learning possible. Consider the cell, that fundamental unit of life enclosed in its delicate membrane. A single cell is both astonishingly complex and remarkably vulnerable. Within its boundaries, thousands of chemical reactions proceed simultaneously. Energy gets generated in mitochondria. Proteins get synthesized according to genetic instructions. Waste products get packaged for removal, and signals get received from the environment beyond the cell membrane. This internal world maintains itself through careful regulation, with feedback mechanisms that adjust production rates, repair damaged components, and respond to changing needs. Cellular injury, the disruption of this ordered internal universe, can occur through countless mechanisms, yet they funnel into several common pathways. Deprive a cell of oxygen, and its mitochondria can no longer produce adequate energy through their usual efficient aerobic processes. The cell switches to less efficient anaerobic metabolism, produces less energy and more waste, and if oxygen deprivation continues, critical functions begin to fail. Membranes lose their integrity, ions flow across barriers they typically respect, enzymes leak from their proper compartments, and the organized complexity of cellular life gives way to disorder. Toxins represent another avenue of cellular injury, chemical substances that interfere with normal cellular operations. Some toxins damage cell membranes directly, creating holes or disrupting the lipid bilayer structure. Others inhibit specific enzymes, bringing particular metabolic pathways to a halt. Heavy metals may bind to proteins and alter their shapes, rendering them non-functional. Free radicals, those chemically reactive molecules with unpaired electrons, can damage DNA, proteins, and lipids through oxidation reactions that the cell struggles to control or repair. The cell possesses defenses against such insults, antioxidant systems, and repair mechanisms, but these defenses have limits. Physical trauma delivers cellular injury through mechanical disruption. When tissue gets crushed or torn, cell membranes rupture, contents spill, and the immediate damage spreads as enzymes and other intracellular molecules find themselves in inappropriate locations. Extreme temperatures cause injury as well. Heat denatures proteins, disrupting the precise three-dimensional shapes upon which their functions depend. Cold slows chemical reactions and can cause ice crystals to form within cells, physically puncturing membranes and organelles from within. Radiation, whether from the sun's ultraviolet rays or from medical imaging or from radioactive materials, injures cells by transferring energy to molecules in ways that break chemical bonds. DNA becomes particularly vulnerable, with radiation potentially causing mutations, strand breaks, or crosslinks between molecules that prevent proper genetic function. Cells possess sophisticated DNA repair machinery, capable of fixing many such injuries, but overwhelming damage or damage to the repair systems themselves can lead to cell death or malignant transformation. Infectious agents represent yet another mechanism of cellular injury. Viruses hijack cellular machinery to reproduce themselves, often destroying the host cell in the process, or so disrupting its function that the cell can no longer serve its intended purpose. Bacteria may release toxins that damage cells or may trigger such vigorous immune responses that the inflammation itself becomes destructive. Parasites and fungi bring their own particular mechanisms of harm, competing for nutrients, releasing toxic metabolic byproducts, or physically disrupting tissue architecture. But perhaps the most fascinating aspect of cellular injury is not the damage itself, but the cell's response to injury. Before a cell dies, it may pass through a state called cellular adaptation, where it changes its structure or function in ways that allow survival under adverse conditions. These adaptations represent the cell's attempt to achieve a new equilibrium, a different kind of homeostasis suited to altered circumstances. Atrophy describes the decrease in cell size or number that occurs when cells experience reduced workload, insufficient nutrients, or inadequate hormonal stimulation. Think of a muscle that loses mass when an injured limb remains immobilized, or the way certain organs shrink after menopause when hormonal support diminishes. The cells have not died, but have scaled back their operations, reduced their protein content, diminished their organelles, achieving a smaller but still viable state. This represents a kind of conservation strategy, reducing metabolic demands when resources or stimulation become scarce. Hypertrophy moves in the opposite direction, an increase in cell size that occurs when cells face increased workload or hormonal stimulation. The heart muscle of someone with high blood pressure may undergo hypertrophy, individual cardiac muscle cells growing larger to generate the greater force needed to pump blood against elevated resistance. Each cell contains more contractile proteins, more mitochondria to fuel the increased work, more of the machinery needed to meet the heightened demand. Unlike atrophy, which we might view as scaling down, hypertrophy represents scaling up, the cell-meeting challenge with growth. Hyperplasia involves an increase not in cell size, but in cell number. Cells that retain the capacity to divide may respond to certain stimuli by proliferating, creating more cells to accomplish necessary functions. The lining of the uterus undergoes hyperplasia monthly under hormonal influence, thickening in preparation for potential pregnancy. Bone marrow increases blood cell production in response to demands for oxygen carrying capacity at high altitude. This multiplication of cells, when properly regulated, serves adaptive purposes. But when regulation fails, hyperplasia can become pathological, contributing to tumor formation. Metaplasia represents perhaps the most striking form of cellular adaptation, where one type of mature cell transforms into another type better suited to environmental stress. In the airways of cigarette smokers, the normal respiratory epithelium, with its delicate ciliated cells specialized for moving mucus and trapped particles upward and out, may transform into tougher stratified squamous epithelium, the kind of layered protective tissue found in skin. This new epithelium resists the irritation of smoke better than the original tissue, but it lacks the cilia needed for proper airway cleaning. Metaplasia thus represents a trade-off, gaining resistance to one kind of stress while losing specialized function. These cellular adaptations occupy a middle ground between normal function and cell death. They represent the cell's flexibility, its capacity to adjust and persist under changed conditions. Yet each adaptation carries potential consequences. Hypertrophy may eventually outstrip blood supply, leaving enlarged cells at the periphery struggling for oxygen and nutrients. Hyperplasia increases the number of cells undergoing division, and with each division comes small risk of DNA copying errors that could lead toward malignancy. Metaplasia trades specialized function for durability, potentially compromising organ performance. When cellular injury exceeds the capacity for adaptation or repair, cell death follows. This final fate can take two distinct forms, each with different implications for surrounding tissue. Necrosis represents traumatic cell death, the consequence of severe injury that disrupts cellular architecture faster than the cell can respond. The cell swells as membrane pumps fail and water floods in. Organelles swell and rupture. Eventually, the cell membrane itself gives way, spilling cellular contents into the surrounding tissue space. These released intracellular molecules, never meant to exist outside the cell, trigger inflammation as the immune system responds to what it recognizes as damage signals. Different patterns of necrosis reflect different types of injury. Coagulative necrosis, common in organs suffering sudden loss of blood supply, leaves behind tissue with maintained general architecture but dead cells, as if the tissue structure has been fixed in place even as cellular life ceased. Liquefactive necrosis occurs when enzymes from dying cells or from inflammatory cells digest tissue into a liquid mass, commonly seen in brain injuries or bacterial infections where enzymatic activity predominates. Caseous necrosis creates a cheese-like appearance in tissue, classically associated with tuberculosis, where the tissue becomes granular and crumbly. Each pattern tells a story about the nature and timing of injury. Apoptosis, in striking contrast to necrosis, represents controlled cell death, a programmed sequence of events where the cell systematically dismantles itself from within. The nucleus condenses, DNA fragments at specific sites, the cell membrane forms blebs and buds, and ultimately the cell breaks into small, membrane-bound packages that neighboring cells or immune cells can easily ingest and dispose of, all without triggering inflammation or damaging adjacent tissue. This represents not cellular disaster, but cellular suicide, often for the greater good of the organism. Apoptosis serves essential functions in normal physiology. During embryonic development, apoptosis sculpts tissue, eliminating cells in the webbing between developing fingers, removing excess neurons that failed to make proper connections, shaping organs through strategic cell removal. In adults, apoptosis maintains balance, eliminating cells with irreparable DNA damage that might otherwise become cancerous, removing aged or damaged cells, controlling cell populations in tissues that continuously regenerate. The process follows an orderly script, triggered by internal sensors that detect damage or by external signals that instruct the cell to die for the community's benefit. The distinction between necrosis and apoptosis matters profoundly because each has different consequences for healing and recovery. Necrosis, with its inflammatory aftermath, may lead to scarring and permanent structural damage. Apoptosis proceeds quietly, causing minimal disruption to tissue organization, allowing clean replacement or simple reduction in cell numbers without architectural distortion. Understanding this difference helps explain why some injuries heal smoothly while others leave lasting marks. Between injury and death, between structural change and functional consequence, lies the remarkable territory of inflammation. This is the body's fundamental response to injury and infection, a complex cascade of events orchestrated by chemical signals, carried out by specialized cells, aimed at containing threats, removing damaged tissue, and initiating repair. Inflammation has earned a complicated reputation in contemporary health discussions, sometimes portrayed as villain, sometimes as hero, but the truth resists such simple categorization. Inflammation is context, timing, and degree. Acute inflammation arrives swiftly in response to injury or infection. You experience its signs each time you cut your finger or develop a sore throat. Redness, heat, swelling, pain, and sometimes loss of function. These cardinal signs, recognized since ancient times, reflect specific vascular and cellular events. Blood vessels at the injury site dilate, increasing blood flow and causing redness and warmth. Those vessels become more permeable, allowing fluid and proteins to leak from bloodstream into tissue, creating swelling. Chemical mediators sensitize nerve endings, producing pain that serves the protective function of making you favor the injured area. The increased vascular permeability that causes swelling serves important purposes beyond the visible puffiness. Antibodies and complement proteins from the blood gain access to tissue spaces where they can combat pathogens. The leaked fluid dilutes toxins and brings in antimicrobial peptides. Meanwhile, white blood cells, the immune system's mobile warriors, receive chemical summons to the site of injury. Endothelial cells lining blood vessels express adhesion molecules that catch passing leukocytes like a molecular Velcro, slow them, allow them to squeeze between endothelial cells and migrate into damaged tissue. Neutrophils arrive first among the white blood cells within hours of injury. These are the rapid response force, cells specialized for engulfing and destroying bacteria and damaged tissue debris. They arrive in large numbers, work intensively, and die relatively quickly at the site. Their accumulated bodies contributing to pus formation when infection is present. Following the neutrophils come monocytes from the bloodstream, which transform into macrophages once in tissue. These larger phagocytic cells continue the work of cleaning up debris, engulfing dead neutrophils along with bacteria and damaged cells. But they also coordinate the next phases of inflammation and healing through the chemical signals they release. The chemical mediators orchestrating inflammation constitute an intricate network of communication. Histamine, released from mast cells and basophils, initiates vascular changes within seconds of injury. Prostaglandins and leukotrienes, produced from membrane phospholipids through enzymatic pathways, amplify inflammation and cause pain. Cytokines, protein messengers released by various cells, coordinate immune cell recruitment and activation. Complement proteins, part of the innate immune system, can directly kill bacteria, opsonize pathogens to make them tastier to phagocytes, and recruit additional inflammatory cells through protein fragments that act as chemoattractants. This symphony of molecules and cells can resolve completely, returning tissue to normal once the threat is neutralized and debris cleared. Macrophages and other cells shift from producing pro-inflammatory signals to releasing anti-inflammatory mediators that actively promote resolution. The vascular changes reverse, swelling subsides, pain diminishes, and tissue regains normal function. This represents the ideal outcome, inflammation having served its protective and preparatory functions before fading away. Yet sometimes inflammation persists, transitioning from acute to chronic when the inciting cause cannot be eliminated or when regulatory mechanisms fail. Chronic inflammation may simmer for months or years, characterized by a different cellular cast than acute inflammation. Lymphocytes and plasma cells become more prominent, along with macrophages that may organize into specialized structures called granulomas when attempting to wall off particularly resistant foreign material or pathogens. The tissue takes on a different character, with ongoing destruction occurring alongside attempted repair, often resulting in progressive scarring that distorts normal architecture. Chronic inflammation drives many common diseases. Atherosclerosis, the arterial disease underlying heart attacks and strokes, involves chronic inflammation in vessel walls. Autoimmune conditions like rheumatoid arthritis represent inflammation misdirected against the body's own tissues. Chronic lung diseases feature persistent inflammation in airways or alveoli. Even obesity is now recognized as a state of low-grade chronic inflammation in adipose tissue. Understanding inflammation's chronic forms helps explain how temporary beneficial responses can, when persistent, contribute to progressive tissue damage and organ dysfunction. The relationship between inflammation and healing brings us to one of pathology's most important processes: tissue repair and regeneration. After injury, after inflammatory responses have cleared damaged tissue and controlled infection, the body faces the task of restoring continuity and function. The way this occurs depends partly on the tissue involved and partly on the extent of damage, with outcomes ranging from perfect regeneration to permanent scarring. Some tissues possess remarkable regenerative capacity. The liver can regenerate substantial portions of lost tissue, hepatocytes dividing to replace lost mass while maintaining architectural organization. Bone heals fractures by regenerating new bone tissue, eventually restoring nearly original strength and structure. Skin closes wounds through a combination of epithelial cell migration and proliferation, often restoring a complete barrier, though the repaired skin may differ slightly from the original in texture or color. Other tissues have limited regenerative capacity. Cardiac muscle, once thought completely unable to regenerate, can replace a tiny percentage of cells over time, but this capacity falls far short of what's needed to repair a large infarct after a heart attack. Neurons in the central nervous system, with few exceptions, cannot regenerate damaged axons across significant distances, rendering spinal cord injuries and strokes permanently debilitating. In these tissues with limited regenerative capacity, repair occurs primarily through scar formation. Scar tissue represents the body's compromised solution when regeneration cannot occur. Fibroblasts, specialized cells that produce collagen and other connective tissue components, proliferate and synthesize new extracellular matrix. This fills the defect left by lost tissue, providing structural continuity and mechanical strength. However, scar tissue lacks the specialized function of the original tissue. A scar in heart muscle doesn't contract. A scar in liver doesn't perform metabolic functions. A scar in kidney doesn't filter blood. The body has achieved continuity at the cost of function. The process of scar formation follows predictable stages. Granulation tissue forms first, a combination of new capillaries, proliferating fibroblasts, and inflammatory cells organized in a loose, pink tissue that fills the wound. Over time, this immature tissue matures into fibrous scar as collagen deposition increases, cells decrease in number, and blood vessels regress. The scar contracts somewhat as specialized fibroblasts called myofibroblasts exert tension, pulling wound edges closer together. Eventually, a relatively acellular, collagen-rich scar remains, visible as a pale line in skin or as fibrous tissue in internal organs. The extracellular matrix, that network of proteins and polysaccharides surrounding cells, deserves attention beyond its role in scar formation because it influences nearly every aspect of tissue behavior. Far from being mere structural scaffolding, the extracellular matrix provides biochemical signals that affect cell survival, proliferation, differentiation, and migration. Cells sense the composition and stiffness of surrounding matrix through surface receptors called integrins, translating mechanical properties into intracellular signals that influence gene expression and cell fate. Collagen, the most abundant protein in the body, provides tensile strength to tissues. More than 20 different collagen types exist, each with specialized functions and distributions. Type 1 collagen predominates in bone, tendons, and skin, providing strength against stretching forces. Type 2 collagen fills cartilage, providing compressive resilience. Type IV collagen forms the scaffolding of basement membranes, those thin sheets that underlie epithelia and surround blood vessels. Genetic defects affecting collagen synthesis or structure cause various heritable disorders, revealing through dysfunction how essential proper collagen is to tissue integrity. Elastin, another matrix protein, allows tissues to stretch and recoil. Abundant in arterial walls, lung tissue, and skin, elastin provides the resilience that lets arteries expand with each heartbeat and return to resting diameter, allows lungs to stretch during inhalation and passively deflate on exhalation, permits skin to accommodate movement and return to original contours. With aging or damage, elastin degradation contributes to arterial stiffening, loss of skin elasticity, and emphysema in lungs. Proteoglycans and glycosaminoglycans, complex molecules composed of protein cores with attached polysaccharide chains, fill spaces in the matrix and regulate tissue hydration. These highly charged molecules attract water, creating the gel-like consistency of cartilage and the cushioning properties of connective tissue. They also bind growth factors and other signaling molecules, creating local reservoirs that can be released when needed. Disruption of proteoglycan metabolism affects tissue hydration and mechanical properties, contributing to conditions like osteoarthritis. The cellular participants in tissue repair include not only the fibroblasts producing matrix, but also endothelial cells forming new blood vessels, a process called angiogenesis. Healing tissue needs blood supply to deliver oxygen and nutrients, remove wastes, and bring immune cells for infection surveillance. Angiogenesis begins when existing vessels sprout new branches, endothelial cells responding to growth factors by loosening their connections, proliferating, and migrating into the healing tissue. These new vessels initially leak and appear disorganized, but they gradually mature, becoming less permeable and developing supporting cells like parasites that stabilize the vessel walls. Growth factors orchestrate much of the repair process through their influences on cell behavior. Vascular endothelial growth factor stimulates angiogenesis. Platelet-derived growth factor and transforming growth factor beta promote fibroblast proliferation and collagen synthesis. Epidermal growth factor enhances epithelial cell migration and proliferation during wound reepithelialization. These molecules work in concert, creating gradients that guide cell movement, sequential signals that coordinate different repair phases, and feedback loops that modulate the intensity and duration of responses. Wound healing in skin illustrates these principles beautifully. Initially, blood from damaged vessels fills the wound, and platelets aggregate to form a hemostatic plug that stops bleeding. These activated platelets release growth factors that initiate the healing cascade. Inflammatory cells arrive to clean the wound. Within days, granulation tissue begins filling the defect from the base upward, while epithelial cells at wound edges proliferate and migrate across the surface, re-establishing the protective barrier. Contraction reduces wound size. Eventually, remodeling reshapes the scar. Though this process continues for months, the collagen being constantly degraded and resynthesized in gradually more organized patterns that increase scar strength. This healing process can go awry in various ways. Inadequate healing leaves wounds open longer than normal, vulnerable to infection and failing to achieve adequate strength. This occurs in diabetics with poor blood sugar control, in patients with compromised circulation, in the severely malnourished, or when repeated trauma disrupts the healing sequence. Excessive healing creates hypertrophic scars or keloids, raised scars that extend beyond original wound boundaries, representing overproduction of collagen and matrix. Some individuals have genetic susceptibility to keloid formation, their fibroblasts responding excessively to injury signals. Wound healing in specialized tissues presents unique challenges. Bone fracture healing involves initial hematoma formation followed by development of a soft callus containing cartilage, which is gradually replaced by hard callus of woven bone, ultimately remodeled into mature lamellar bone aligned with mechanical stress lines. Tendon healing requires restoration of the highly organized parallel collagen fiber arrangement needed for tensile strength, a challenging task that explains why tendon injuries often result in weakened, re-injury-prone tissue. Nerve healing in the peripheral nervous system can occur if the supporting Schwann cells survive to guide regenerating axons, but success depends on gaps being small enough to cross and the distal targets remaining viable. As we consider these mechanisms of injury, inflammation, and repair, patterns emerge that help us understand disease processes more broadly. We see that pathology represents not random chaos, but the body responding to challenges with programmed sequences, with adaptive attempts that sometimes succeed and sometimes create new problems. We recognize that the boundary between health and disease is not a sharp line, but a spectrum, with many intermediate states where function is altered but not lost, where adaptation compensates but at a cost. Consider fever that rise in body temperature during infection. Rather than representing simple damage from pathogens, fever reflects an orchestrated immune response. Immune cells release pyrogens, molecules that reset the hypothalamic thermostat to a higher setting. The body shivers to generate heat, blood vessels constrict to reduce heat loss, and temperature climbs. This elevated temperature enhances immune cell function and may inhibit bacterial growth. Fever represents the body making itself a less hospitable environment for invaders, trading temporary discomfort for immunological advantage. Yet excessive fever can become dangerous, denaturing proteins and stressing organs, illustrating again how adaptive responses have optimal ranges beyond which they become harmful. Pain, another common symptom, serves protective functions by alerting us to tissue damage and encouraging behaviors that promote healing. The inflammatory mediators that sensitize nerve endings ensure we notice injury and treat it gently. Yet chronic pain, persisting long after healing completes or arising from nerve damage itself, represents a maladaptive state where the protective signal has become suffering without purpose. Understanding pain's mechanisms within pathology helps distinguish beneficial acute pain from pathological chronic pain requiring different management approaches. Edema, the accumulation of fluid in tissue spaces, can result from various pathological processes. Increased vascular permeability during inflammation allows fluid leak. Heart failure, reducing the heart's pumping efficiency, causes blood to back up in veins, increasing pressure that forces fluid from vessels into tissues. Kidney disease, impairing protein retention in blood, reduces the oncotic pressure that normally keeps fluid in circulation, allowing it to escape into tissues. Lymphatic obstruction prevents normal fluid drainage from tissues back to circulation. Each mechanism produces swelling, but understanding the underlying cause guides appropriate intervention. The language of pathology includes many terms describing tissue changes visible to the examining eye or under the microscope. Hyperemia refers to increased blood in tissue, causing redness. Congestion describes blood accumulation due to impaired outflow rather than increased inflow. Hemorrhage indicates blood outside vessels, from tiny petechiae barely visible on skin to massive bleeding into body cavities. Thrombosis names clot formation within vessels. Embolism describes material, whether clot fragment or fat or air, traveling through circulation and lodging in a vessel distant from its origin. Infarction is tissue death from inadequate blood supply, typically after thrombosis or embolism blocks arterial flow. These descriptive terms form the vocabulary through which pathologists communicate findings, but beneath the terminology lie the fundamental mechanisms we've explored. Thrombosis occurs when endothelial injury, abnormal blood flow, or hypercoagulable states disrupt the usual balance, preventing clot formation in intact vessels. Infarction reflects cellular injury from oxygen deprivation. Hemorrhage may result from vessel wall weakness, trauma, or clotting abnormalities. Each observation connects to underlying biological processes. The concept of etiology addresses the question of what causes disease, and here we encounter remarkable variety. Genetic mutations may be inherited or arise spontaneously, causing disease through production of abnormal proteins or loss of essential protein functions. Infections introduce pathogens whose metabolic activities and immune responses they provoke damaged tissue. Nutritional deficiencies deprive cells of essential building blocks or regulatory molecules. Toxins from environment or metabolism interfere with cellular processes. Physical forces cause trauma. Immune system dysfunction leads to autoimmunity or immunodeficiency. Often, diseases arise from multiple interacting factors rather than single causes, genetics providing susceptibility while environment provides triggers. Pathogenesis, distinct from etiology, describes the sequence of events by which an etiologic factor produces disease. A genetic mutation causing cystic fibrosis is the etiology, but pathogenesis describes how that mutation leads to abnormal chloride channel function, which causes thick mucus in airways, which obstructs airflow and traps bacteria, which leads to chronic infection and inflammation, which damages lung tissue progressively over years. Understanding pathogenesis illuminates where interventions might interrupt disease progression even when the underlying cause cannot be eliminated. This brings us gently toward the close of our first hour together, having established foundational concepts that undergird all subsequent understanding of disease. We've explored how cells respond to injury with adaptation or death, how inflammation mobilizes the body's defenses while carrying potential for harm when chronic, how tissues attempt repair through regeneration or scar formation, and how the extracellular environment shapes cellular behavior. We've begun to appreciate pathology not as a catalog of disasters, but as the study of biological processes under stress, revealing both vulnerability and resilience. The territory ahead will build on these foundations, examining specific disease mechanisms in greater detail, exploring how disturbances cascade through interconnected systems, and understanding how pathological processes manifest in symptoms and signs. But the principles remain constant: the body as a complex adaptive system, disease as disturbance of regulation, and healing as the restoration of balance or achievement of new equilibrium. Even now, in your own body, these processes continue their intricate dance, cells replacing themselves, immune surveillance detecting and eliminating abnormal cells, minor injuries repairing without your awareness, homeostatic mechanisms maintaining the narrow ranges within which life flourishes. There is profound elegance in these mechanisms, beauty in their complexity, and reassurance in their constancy. We continue our journey through the landscape of pathology, returning to these mechanisms with deeper attention, building upon the foundation we've established together. You've been introduced to the fundamental responses of cells and tissues to injury, the inflammatory cascade that mobilizes defense and repair, and the basic vocabulary through which we describe pathological changes. Now we venture further into specific mechanisms that drive disease processes, examining how disturbances in particular systems create cascades of dysfunction, how the body's own protective mechanisms can paradoxically contribute to damage, and how understanding these patterns illuminates the logic underlying seemingly diverse conditions. Let us begin by expanding our understanding of cellular injury beyond the general principles we've touched upon, diving into the molecular events that determine whether a cell survives stress, adapts to new circumstances, or succumbs to death. The cell membrane, that delicate phospholipid bilayer studded with proteins, serves as the primary barrier between the cell's ordered interior and the external environment. Maintaining the integrity of this barrier requires constant energy expenditure, powering the ion pumps that keep sodium predominantly outside and potassium predominantly inside, that remove calcium from the cytoplasm, that maintain the electrical and chemical gradients essential to cellular function. When energy production falters, whether from oxygen deprivation, mitochondrial dysfunction, or toxin exposure that inhibits energy-generating pathways, these pumps begin to fail. Sodium seeps inward, bringing water with it through osmosis, causing the cell to swell. Calcium floods in from the extracellular space and from intracellular stores normally kept sequestered. This calcium influx triggers multiple destructive processes. It activates enzymes called phospholipases that attack membrane phospholipids, degrading the very barriers meant to contain cellular contents. It stimulates proteases that degrade structural and functional proteins. It triggers endonucleases that fragment DNA. The cell, unable to maintain the gradients and compartmentalization upon which life depends, slides toward necrosis. Mitochondria occupy a particularly crucial position in determining cellular fate. These organelles, evolutionary descendants of ancient bacteria that entered into symbiotic relationship with early eukaryotic cells, generate the vast majority of cellular ATP through oxidative phosphorylation. They also serve as central regulators of apoptosis, the programmed cell death we discussed earlier. When mitochondria become damaged or when cellular stress reaches certain thresholds, the outer mitochondrial membrane becomes permeabilized, releasing proteins normally confined to the space between mitochondrial membranes. Among these released proteins is cytochrome C, which in the cytoplasm triggers activation of caspases, the executioner enzymes of apoptosis. The endoplasmic reticulum, that elaborate network of membranes where proteins get synthesized and folded into their functional three-dimensional shapes, contributes its own form of stress response. When misfolded proteins accumulate beyond the endoplasmic reticulum's capacity to refold or degrade them, a condition called ER stress develops. the cell responds with the unfolded protein response, initially an adaptive mechanism that slows protein synthesis, increases production of molecular chaperones that assist protein folding, and enhances degradation pathways for misfolded proteins. However, if ER stress persists and cannot be resolved, the unfolded protein response shifts from protective to pro-apoptotic, triggering cell death rather than allowing continued existence in a dysfunctional state. Free radicals and oxidative stress represent a pervasive threat to cellular integrity, arising both from normal metabolism and from external sources. Free radicals are molecules with unpaired electrons, making them highly reactive and prone to stealing electrons from other molecules, thereby damaging DNA, proteins, and lipids through oxidation. Superoxide hydrogen peroxide and hydroxyl radicals are among the most significant reactive oxygen species generated during normal mitochondrial respiration. Cells combat these molecules with antioxidant systems, including enzymes like superoxide dismutase, catalase, and glutathione peroxidase, along with non-enzymatic antioxidants like vitamin C and E. When free radical generation overwhelms antioxidant defenses, oxidative stress ensues. DNA suffers base modifications and strand breaks that can lead to mutations if not properly repaired. Lipid peroxidation creates chain reactions where oxidized lipids propagate damage through membranes, increasing permeability and disrupting membrane-bound protein functions. Protein oxidation alters enzyme activities and structural protein integrity. The accumulated oxidative damage contributes to aging and plays roles in numerous diseases from atherosclerosis to neurodegenerative conditions to cancer. Yet, free radicals are not purely villainous. They also serve essential functions in immune responses where phagocytes deliberately generate reactive oxygen species to kill ingested bacteria. The genetic material itself, that precisely ordered sequence of nucleotide bases carrying hereditary information and directing protein synthesis, faces constant threats requiring vigilant maintenance. DNA damage occurs routinely from metabolic byproducts, from environmental exposures to radiation and chemicals, from errors during DNA replication, and from spontaneous chemical reactions like depurination, where purine bases detach from the DNA backbone. Cells possess elaborate DNA repair mechanisms, different systems specialized for different types of damage. Base excision repair removes single damaged bases. Nucleotide excision repair cuts out larger lesions. Mismatch repair corrects errors that escape proofreading during replication. Double-strand break repair rejoins severed DNA strands through either non-homologous end joining or homologous recombination. When DNA damage exceeds repair capacity or damages the repair machinery itself, consequences depend on the cell's state and identity. In dividing cells, checkpoints in the cell cycle arrest progression until repairs complete, preventing propagation of mutations to daughter cells. If damage proves irreparable, checkpoint proteins like p53, often called the guardian of the genome, trigger apoptosis, sacrificing the damaged cell to protect the organism from potential malignant transformation. In non-dividing cells, accumulated DNA damage contributes to cellular senescence, a state where cells remain metabolically active but can no longer divide, or to cellular dysfunction as proteins synthesized from damaged genetic templates prove defective. Cellular senescence deserves particular attention as a phenomenon bridging normal aging, cancer prevention, and age-related disease. Senescent cells accumulate with age in various tissues, characterized by permanent growth arrest, resistance to apoptosis, and secretion of numerous inflammatory mediators, growth factors, and proteases, collectively termed the senescence-associated secretory phenotype. This secretory activity affects neighboring cells and tissue architecture. While cellular senescence prevents proliferation of cells with oncogenic mutations, serving as tumor suppressor mechanism, the senescence-associated secretory phenotype contributes to chronic inflammation, tissue dysfunction, and potentially to age-related diseases from arthritis to atherosclerosis. Moving from cellular to tissue-level phenomena, we find hemodynamic disorders, disturbances in blood flow and fluid distribution that profoundly affect tissue health. The circulatory system operates as a closed loop under pressure, with blood flowing from high-pressure arteries through capillary beds where exchange occurs, then back through low-pressure veins to the heart. This circuit depends on adequate blood volume, proper vessel integrity, effective cardiac pumping, and appropriate vessel tone. Disruption at any point creates pathological consequences. Edema, which we mentioned briefly earlier, merits deeper examination for its multiple mechanisms and clinical significance. Fluid normally moves between vascular space and interstitial space, based on the balance between hydrostatic pressure, pushing fluid outward, and oncotic pressure from plasma proteins pulling fluid inward. At the arterial end of capillaries, hydrostatic pressure exceeds oncotic pressure, pushing fluid into tissues. At the venous end, oncotic pressure exceeds the now reduced hydrostatic pressure, pulling fluid back into circulation. The lymphatic system drains excess fluid that doesn't return directly to blood vessels. Edema develops when this balance shifts, allowing fluid accumulation in interstitial spaces. Increased hydrostatic pressure causes edema in heart failure, where inadequate cardiac output leads to blood backing up in veins, increasing venous pressure transmitted backward to capillaries. The fluid shift into tissues reduces blood volume, triggering kidney mechanisms that retain salt and water to restore volume. But this added fluid simply worsens the edema, creating a vicious cycle. Regional edema occurs when veins become obstructed by thrombus or when venous valves fail, causing blood to pool in affected limbs. Decreased oncotic pressure produces edema when plasma protein concentration falls. The liver synthesizes most plasma proteins, particularly albumin, which provides roughly 75% of plasma oncotic pressure. Liver disease reducing protein synthesis or kidney disease, allowing protein loss into urine both. Reduce plasma oncotic pressure, permitting fluid to escape from vessels into tissues. Severe malnutrition limiting protein intake produces similar effects. The swollen bellies of kwashiorkor representing edema from protein deficiency despite overall caloric inadequacy. Increased vascular permeability, such as occurs during inflammation, allows protein to leak into interstitium, reducing the oncotic gradient that normally favors fluid retention in vessels while simultaneously increasing interstitial oncotic pressure, both effects promoting edema. The puffy, swollen tissue around a skin wound or infected area demonstrates this mechanism. Lymphatic obstruction, whether from surgical removal of lymph nodes, parasitic infections that block lymphatic channels, or malignancy compressing lymphatic vessels, prevents normal fluid drainage, causing lymphedema in affected areas. The consequences of edema extend beyond swelling. Pulmonary edema, fluid accumulation in lung alveoli, impairs gas exchange, causing shortness of breath and, if severe, respiratory failure. Cerebral edema, Swelling of brain tissue within the rigid confines of the skull raises intracranial pressure with potentially devastating neurological effects. Chronic peripheral edema predisposes to skin breakdown and infection. Understanding edema mechanisms guides treatment, whether through diuretics reducing fluid volume, measures to improve cardiac output, protein replacement, or treatment of underlying inflammation. Hyperemia and congestion both involve increased blood volume in tissue, but through different mechanisms with different implications. Hyperemia represents active arterial dilation, bringing increased blood flow to tissue, the redness of inflamed skin, or the flushed face during exercise reflecting arteriolar dilation and increased tissue perfusion. This typically benefits tissue by delivering more oxygen and nutrients. Congestion, in contrast, results from impaired venous outflow, blood accumulating in tissues because it cannot drain properly. Congested tissue appears blue-red from the high proportion of deoxygenated blood, and chronic congestion leads to tissue hypoxia despite increased blood volume because the stagnant blood has already surrendered its oxygen. Chronic passive congestion in the liver provides a striking example. When the right side of the heart fails to pump effectively, blood backs up into the inferior vena cava and hepatic veins. Liver sinusoids become engorged with blood, and hepatocytes in the center of liver lobules farthest from arterial blood supply suffer hypoxic injury and eventually die. The gross appearance of the cut surface of such a liver resembles a nutmeg, with pale areas of fatty change alternating with dark areas of congestion, giving rise to the term nutmeg liver. Over time, chronic congestion can lead to cardiac cirrhosis, fibrosis developing in response to repeated hepatocyte injury, hemorrhage, the escape of blood from vessels, ranges from trivial to life-threatening depending on volume, rate, and location. Massive hemorrhage causes shock, that state of inadequate tissue perfusion where circulatory collapse threatens organ function. The body responds to hemorrhage with compensatory mechanisms. Sympathetic nervous system activation constricts blood vessels and increases heart rate, attempting to maintain blood pressure. Kidney mechanisms retain salt and water, expanding plasma volume, and bone marrow increases red blood cell production to replace lost oxygen carrying capacity. However, these compensations have limits, and severe hemorrhage requires external intervention with fluid resuscitation and transfusion. Even small hemorrhages carry significance depending on location. Hemorrhage into the brain causes stroke, damaged neurons often dying quickly from interruption of blood supply and from mechanical compression by accumulating blood. Hemorrhage into the pericardial sac surrounding the heart can cause cardiac tamponade, the blood-filled sac compressing the heart and preventing proper filling. Chronic slow bleeding, such as from gastrointestinal lesions, may go unnoticed until anemia develops from iron loss, manifesting as fatigue and pallor rather than acute symptoms. Thrombosis, the formation of blood clots within vessels, represents a crucial pathological process with wide-ranging implications. Normally, blood remains fluid within intact vessels through careful regulation of coagulation and anticoagulation systems. The vascular endothelium actively prevents clotting, secreting anticoagulant molecules, preventing platelet adhesion through its smooth surface, and producing prostacyclin that inhibits platelet aggregation. When vessel injury occurs, exposed subendothelial collagen triggers platelet adhesion and activation, initiating the coagulation cascade that generates fibrin strands to strengthen the platelet plug. Thrombosis within intact vessels occurs when this delicate balance shifts. Virchow's triad, formulated in the 19th century, identifies three predisposing factors: endothelial injury, abnormal blood flow, and hypercoagulability. Endothelial injury from atherosclerosis, vasculitis, or indwelling catheters exposes procoagulant surfaces. Abnormal flow, whether the stasis of prolonged immobility or the turbulence at vessel bifurcations, disrupts the laminar flow that normally keeps platelets away from vessel walls and prevents accumulation of activated clotting factors. Hypercoagulability arises from genetic disorders affecting clotting factor regulation, from cancer-associated procoagulant release, from pregnancy-related hormonal changes, or from various acquired conditions. Arterial thrombi typically form at sites of endothelial injury, particularly where atherosclerotic plaques rupture or erode. These thrombi are rich in platelets, reflecting the high shear forces in arteries that promote platelet adhesion. They may grow to occlude the vessel, causing ischemia in downstream tissue, or fragments may break off as emboli. Venous thrombi develop more commonly in settings of stasis and hypercoagulability, contain more fibrin and trapped red blood cells, and have a propensity to embolize to the lungs as pulmonary emboli. Embolism describes any intravascular mass carried by blood flow from one site to another. Most emboli are thrombotic, detached portions of blood clots traveling through circulation until lodging in vessels too narrow to pass. A deep vein thrombosis in the leg may give rise to emboli that travel through the right heart into pulmonary arteries, potentially causing sudden death if a large vessel becomes occluded. Arterial emboli often originate from the left heart, where thrombi form in fibrillating atria or on damaged heart valves, then travel into systemic circulation, lodging in brain, kidneys, spleen, or limbs depending on anatomy and chance. Non-thrombotic emboli include fat emboli from bone marrow entering circulation after fractures, air emboli introduced during medical procedures or trauma, amniotic fluid emboli during complicated deliveries, and tumor emboli where cancer cells enter vessels and travel to distant sites, the latter representing a mechanism of metastatic spread. Each type of embolus carries characteristic risks and clinical presentations, but all share the potential for sudden vessel occlusion and ischemic injury to affected tissue. Infarction, tissue death from inadequate blood supply, represents the endpoint of vascular occlusion, whether from thrombosis, embolism, or other mechanisms. The morphology and consequences of infarction depend on the tissue's vascular anatomy and metabolic demands. Organs with dual blood supply or rich collateral circulation may avoid infarction despite occlusion of one vessel. The lung receives blood from both pulmonary arteries and bronchial arteries, making pulmonary infarction uncommon unless pulmonary venous drainage is also compromised. The brain has limited collateral circulation in many areas, making it exquisitely vulnerable to infarction, with neurons beginning to die within minutes of blood flow cessation. Infarcts are classified as either anemic or hemorrhagic. Anemic or pale infarcts occur in solid organs with end arterial circulation, where vessel occlusion produces a zone of dead tissue that appears pale because it contains no blood. Myocardial infarction and splenic infarction exemplify this pattern. Hemorrhagic or red infarcts develop in tissues with dual circulation or loose architecture, where blood from adjacent vessels can seep into the infarcted zone, or when venous occlusion causes blood to back up into dying tissue. Pulmonary infarcts are typically hemorrhagic, as are infarcts in the gut when mesenteric vessels become obstructed. The tissue response to infarction follows patterns we've discussed. Inflammation clears dead tissue, granulation tissue forms, and scar replaces functional tissue. In the heart, a myocardial infarction heals over several weeks, initially showing an acute inflammatory infiltrate, then granulation tissue with new capillaries and fibroblasts, and finally a mature collagen-rich scar. This scar provides structural continuity but cannot contract like normal myocardium, potentially compromising heart function. Moreover, the infarct healing process creates vulnerabilities, with the risk of ventricular rupture highest when granulation tissue is most abundant and before scar maturation provides adequate tensile strength. Shock represents a final common pathway where various insults lead to inadequate tissue perfusion, cellular hypoxia, and if uncorrected, multi-organ failure and death. Different mechanisms produce shock. Cardiogenic shock from pump failure when the heart cannot generate adequate output. Hypovolemic shock from fluid loss through hemorrhage, burns, or severe dehydration. Distributive shock from inappropriate vasodilation, as in sepsis or anaphylaxis. And obstructive shock from mechanical impediments to circulation such as cardiac tamponade or massive pulmonary embolism. Regardless of initiating mechanism, shock produces a common sequence of cellular and organ dysfunction. Inadequate perfusion starves cells of oxygen, forcing shift to anaerobic metabolism that produces far less ATP while generating lactic acid. Cellular ion pumps fail, membranes depolarize, and cellular injury ensues. The body attempts compensation through sympathetic activation, shunting blood from skin, gut, and kidneys toward brain and heart. But this sacrifices some tissues to preserve others. If shock persists, the compensatory mechanisms prove inadequate or even counterproductive. Intense vasoconstriction reduces organ perfusion further. Endothelial cells, damaged by hypoxia and inflammatory mediators, become dysfunctional and permeable. Microvascular thrombi form. Multiple organs begin failing simultaneously. The progression from reversible to irreversible shock represents a critical transition. Early shock responds to intervention restoring adequate perfusion, with tissues recovering once oxygen delivery resumes. Irreversible shock persists despite correction of the initiating problem, cellular and tissue damage having progressed beyond the point of recovery. The kidneys develop acute tubular necrosis. The lungs experience diffuse alveolar damage in acute respiratory distress syndrome. The liver shows centrilobular necrosis. The gut mucosa sloughs, and the brain suffers ischemic injury. This multiple organ dysfunction syndrome carries high mortality, the body's interconnected systems failing in cascade. Understanding hemodynamic disorders illuminates the fundamental importance of adequate perfusion. Every tissue depends on continuous delivery of oxygen and nutrients with removal of metabolic wastes. Disturbances in this delivery system, whether from heart failure, vascular obstruction, or distributive abnormalities, rapidly translate into cellular dysfunction and tissue injury. The compensatory mechanisms, though initially beneficial, have limits and can themselves become pathological when pushed to extremes. We turn now to examine how the immune system, that elaborate network of cells and molecules defending against infection and maintaining tissue integrity, can itself become a source of pathology. Immune-mediated injury encompasses a spectrum from hypersensitivity reactions, where immune responses prove excessive or misdirected, to autoimmunity, where the immune system attacks the body's own tissues, to immunodeficiency, where inadequate immunity permits opportunistic infections and malignancy. Hypersensitivity reactions are classified into 4 types based on their immunological mechanisms, each producing distinct clinical patterns. Type 1 hypersensitivity, familiar to many as allergy or anaphylaxis, involves IgE antibodies bound to mast cells and basophils. Upon re-exposure to antigen, the allergen cross-links surface IgE, triggering massive degranulation and release of histamine, leukotrienes, and other mediators that cause vasodilation, increased vascular permeability, smooth muscle contraction, and mucus secretion. The localized response produces hay fever or asthma. The systemic response produces anaphylaxis, a potentially fatal syndrome of widespread vasodilation, causing shock, bronchospasm impairing breathing, and angioedema potentially obstructing the airway. Type 2 hypersensitivity involves antibodies directed against antigens present on cell surfaces or in tissue matrices. These antibodies cause damage through several mechanisms: complement activation leading to cell lysis, opsonization marking cells for phagocytic destruction, or antibody-dependent cellular cytotoxicity, where natural killer cells attack antibody-coated targets. Blood transfusion reactions exemplify this mechanism, where antibodies against ABO blood group antigens attack transfused red cells bearing foreign antigens. Autoimmune hemolytic anemia represents the same mechanism directed against one's own red cells. Goodpasture syndrome involves antibodies attacking basement membrane in lungs and kidneys, producing hemorrhage and renal failure. Type 3 hypersensitivity arises from immune complex deposition, where soluble antigen-antibody complexes form in circulation and deposit in tissues, particularly in blood vessel walls, kidney glomeruli, and joint spaces. Complement activation at these sites recruits inflammatory cells whose attempts to clear the complexes damage surrounding tissue. Systemic lupus erythematosus often involves this mechanism, immune complexes depositing in various organs, producing widespread inflammation. Post-streptococcal glomerulonephritis develops when immune complexes deposit in kidney glomeruli after certain throat infections, causing nephritis that usually resolves but occasionally progresses to chronic kidney disease. Type IV hypersensitivity, also called delayed type hypersensitivity, differs from the others in being mediated by T cells rather than antibodies. Previously sensitized T cells encounter antigen, become activated, and recruit macrophages that cause tissue injury through release of cytokines and reactive oxygen species. The tuberculin skin test exploits this mechanism. Prior exposure to tuberculosis antigens producing a delayed inflammatory reaction when antigen is injected into skin. Contact dermatitis from poison ivy or nickel jewelry represents this mechanism as well. Some forms of transplant rejection involve type IV hypersensitivity, with T cells recognizing foreign HLA molecules on graft tissue and orchestrating rejection. Autoimmunity, the immune response against self-antigens, arises when tolerance mechanisms fail. The immune system normally distinguishes self from non-self through processes that eliminate or inactivate lymphocytes recognizing self-antigens. Central tolerance operates in thymus for T cells and bone marrow for B cells, destroying cells with high-affinity self-reactive receptors. Peripheral tolerance mechanisms include anergy, where self-reactive cells become functionally inactive, suppression by regulatory T cells, and deletion through apoptosis. When these safeguards fail, autoimmune disease may develop. Some autoimmune diseases demonstrate organ-specific autoimmunity. Hashimoto thyroiditis involves antibodies against thyroid proteins, causing thyroid inflammation and eventual hypothyroidism. Type 1 diabetes results from T-cell-mediated destruction of insulin-producing beta cells in pancreatic islets. Graves' disease features antibodies that stimulate the thyroid receptor, causing hyperthyroidism. These conditions reflect a breakdown in tolerance toward specific self-antigens. Systemic autoimmune diseases involve immune responses against widespread self-antigens. Systemic lupus erythematosus produces antibodies against nuclear components, forming immune complexes that deposit in multiple organs. Rheumatoid arthritis features inflammation of joint synovium driven by complex interactions of autoantibodies, immune cells, and inflammatory mediators. Scleroderma involves autoimmunity, inflammation, and fibrosis affecting skin and internal organs. The mechanisms driving autoimmunity in these conditions remain incompletely understood but involve genetic susceptibility, environmental triggers, and disturbances in immune regulation. Immunodeficiency, whether inherited or acquired, removes the protection that normally prevents infection. Primary immunodeficiency disorders result from genetic defects affecting immune system development or function. Severe combined immunodeficiency represents the most profound form, with defective T-cell and B-cell function, leaving affected individuals vulnerable to overwhelming infections from bacteria, viruses, fungi, and protozoa that pose little threat to individuals with intact immunity. Less severe primary immunodeficiencies may affect particular components of immunity, such as antibody production or complement function, producing vulnerability to specific types of infection. Secondary immunodeficiency results from damage to a previously normal immune system. Malnutrition impairs immune function, particularly cell-mediated immunity. Cancer chemotherapy and radiation therapy suppress bone marrow production of immune cells. Immunosuppressive medications given to prevent transplant rejection or treat autoimmune disease deliberately suppress immunity to achieve therapeutic goals while accepting increased infection risk. HIV infection causes acquired immunodeficiency syndrome by destroying CD4 positive T cells, progressively eroding cell-mediated immunity and permitting opportunistic infections with organisms that rarely cause disease in immunocompetent individuals. The consequences of immunodeficiency extend beyond increased infection susceptibility. Immune surveillance normally eliminates cells with oncogenic mutations, and immunodeficiency increases cancer risk, particularly for virally associated malignancies and lymphomas. The inflammatory response to infection may be blunted in immunodeficient individuals, masking the typical signs of infection and delaying diagnosis. Treating infections in immunocompromised hosts requires understanding their specific immune defects to anticipate likely pathogens and choose appropriate antimicrobials. As we near the midpoint of our exploration, we recognize how these various mechanisms interconnect. Hemodynamic disturbances cause tissue injury that triggers inflammation. Immune responses meant to protect can themselves damage tissue. Genetic vulnerabilities combine with environmental exposures to produce disease. The boundaries between categories blur when we examine specific diseases, which often involve multiple overlapping mechanisms. A myocardial infarction begins with thrombosis, produces infarction from ischemia, triggers inflammation, heals through scar formation, and and may lead to heart failure with resulting congestion and edema throughout the body. This interconnectedness reflects the fundamental nature of the body as an integrated system where disturbance in one area propagates through anatomical and functional connections. Understanding disease requires attention to these connections, to the cascades and feedback loops that amplify or dampen initial insults, to compensatory mechanisms that maintain function until they exhaust themselves or become pathological in their own right. The wisdom lies not in memorizing isolated facts, but in grasping the principles that allow prediction of how disturbances will propagate and what interventions might interrupt pathological cascades. Even now, your own body demonstrates these principles in miniature. Minor injuries occur and repair without your awareness. Immune cells circulate, surveilling for abnormal cells. Homeostatic mechanisms adjust to your position, activity level, and environment. When you consider the complexity of these systems, the remarkable aspect is not that disease occurs, but that health persists as reliably as it does. That robustness and redundancy allow function to continue despite constant microscopic perturbations. In understanding pathology, we learn to appreciate the elegance of normal function, to see health not as the absence of pathology, but as the successful integration of countless processes maintaining themselves within viable ranges despite continuous challenges. We arrive now at the third portion of our journey through pathology's landscape, having established foundational principles and explored specific mechanisms of injury and immune dysfunction. The territory before us examines how cells grow, divide, and sometimes lose the regulatory constraints that normally govern these processes. We will explore neoplasia, that transformation of normal cells into populations that grow autonomously, and we will examine how infections interact with host tissues, how nutritional and environmental factors shape disease, and how genetic variations contribute to pathological states. Throughout, we maintain our focus on mechanisms rather than mere description, seeking to understand the biological logic underlying these processes. The capacity for cell division represents one of life's fundamental characteristics, essential for growth during development, for tissue maintenance throughout life, and for repair after injury. Yet this capacity requires exquisite regulation, with cells dividing only when and where needed, responding to signals from their environment that indicate space availability, adequate resources, and tissue requirements. The cell cycle, that ordered sequence of events through which cells duplicate their contents and divide into two daughter cells, normally proceeds under strict surveillance, with checkpoints ensuring that each phase completes properly before the next begins. Multiple signals influence whether cells enter the cell cycle or remain quiescent. Growth factors binding to cell surface receptors trigger intracellular signaling cascades that ultimately affect gene expression, promoting production of proteins needed for cell cycle progression. Contact with neighboring cells generally inhibits division through contact inhibition, while loss of such contact, as occurs at wound edges, removes this inhibition and permits proliferation. The extracellular matrix provides signals through integrins, with appropriate matrix attachments serving as a prerequisite for cell cycle entry. Cells deprived of proper matrix contact often undergo a form of apoptosis called anoikis, preventing them from proliferating in inappropriate locations. Within the cell cycle itself, checkpoints monitor conditions before permitting progression. The G1 checkpoint, sometimes called the restriction point, assesses whether conditions favor division, examining growth factor signaling, nutrient availability, and cell size before committing to DNA synthesis. Once past this checkpoint, the cell becomes committed to completing the cycle. The G2 checkpoint verifies that DNA replication has completed accurately before allowing mitosis to begin. The metaphase checkpoint ensures proper chromosome attachment to the mitotic spindle before permitting the irreversible separation of sister chromatids. These checkpoints depend on sensor proteins that detect problems and effector proteins like p53 that halt cycle progression until problems are resolved or trigger apoptosis if damage proves irreparable. Neoplasia, literally meaning new growth, describes abnormal cell proliferation that persists even after the inciting stimulus has been removed. Unlike the controlled proliferation of wound healing that ceases once tissue continuity is restored, or the regulated turnover of tissues like intestinal epithelium where cell birth balances cell death, neoplastic growth continues autonomously. The resulting mass of cells constitutes a tumor or neoplasm, which may be benign or malignant based on its biological behavior and potential to invade surrounding tissue or spread to distant sites. Benign tumors grow slowly, remain localized, and are typically well differentiated, meaning their cells resemble the normal tissue of origin. A lipoma, a benign tumor of adipose tissue, contains cells that look and function much like normal fat cells, simply growing in excessive numbers at an inappropriate location. Benign tumors usually compress surrounding structures rather than infiltrating them, often developing a fibrous capsule at their periphery that facilitates surgical removal. While benign tumors rarely threaten life directly, they can cause problems through mass effect, compressing nearby structures, or through hormone production if they arise from endocrine tissue. Malignant tumors, collectively termed cancer, demonstrate invasive growth, infiltrating and destroying adjacent tissues. Their cells typically show poor differentiation, departing from the normal appearance and function of their tissue of origin. They possess the capacity for metastasis, spreading to distant sites through blood vessels or lymphatic channels to establish secondary growths. This combination of local invasion and metastatic potential makes malignant tumors dangerous, difficult to eradicate completely, and responsible for most cancer-related mortality. Understanding what transforms normal cells into malignant ones occupies a central place in pathology and medicine. Carcinogenesis, the multi-step process through which normal cells become cancer cells, typically requires accumulation of multiple genetic alterations affecting genes that regulate cell growth, survival, and differentiation. These genetic changes affect two main categories of genes. Proto-oncogenes normally promote cell growth and proliferation, encoding growth factor receptors, signal transduction proteins, or transcription factors that stimulate cell cycle progression. When mutated to become oncogenes, these genes become hyperactive or overexpressed, driving excessive proliferation. Tumor suppressor genes normally restrain cell division, induce apoptosis in damaged cells, or promote DNA repair. Loss of tumor suppressor gene function removes brakes on cell proliferation. The concept of multiple hits explains why most cancers develop over years or decades despite cells encountering carcinogens throughout life. A single mutation typically proves insufficient for malignant transformation. Rather, cells must accumulate mutations in several genes, controlling different aspects of growth regulation before acquiring the full malignant phenotype. Colorectal cancer development illustrates this progression. Normal colonic epithelium may acquire a mutation in the APC tumor suppressor gene, leading to formation of a small benign polyp. Additional mutations in genes like KRAS and P53 over subsequent years drive progression from small polyp to large polyp to carcinoma, each mutation conferring additional growth advantages and moving the cell population further from normal regulatory control. The hallmarks of cancer enumerate the capabilities that cells must acquire during carcinogenesis. Self-sufficiency in growth signals allows cancer cells to proliferate without external growth factor stimulation, often through mutations activating growth factor receptors or downstream signaling proteins. Insensitivity to growth inhibitory signals permits continued proliferation despite contact inhibition and other restraining influences. Evasion of apoptosis, frequently through loss of 53 function, allows cells with DNA damage to survive rather than dying as they normally would. Limitless replicative potential comes from activation of telomerase, the enzyme that maintains telomeres and prevents the chromosomal shortening that normally limits cell divisions. Sustained angiogenesis provides the blood supply needed to sustain tumor growth beyond microscopic size. Tissue invasion and metastasis emerge from changes allowing cells to detach from neighbors, degrade extracellular matrix, and migrate through tissue barriers. Recent additions to the hallmarks list include reprogramming energy metabolism, with cancer cells often relying on glycolysis even in the presence of oxygen, a phenomenon called the Warburg effect. This seems metabolically inefficient but provides biosynthetic precursors needed for rapid cell division. Evading immune destruction allows cancer cells to avoid elimination by immune surveillance. Tumor-promoting inflammation reveals how the inflammatory cells and mediators in the tumor microenvironment can actually foster tumor growth rather than eliminating malignant cells. Genomic instability and mutation accelerate the acquisition of other hallmarks by increasing mutation rates. Carcinogens, agents that cause or promote cancer development, work through varied mechanisms. Some carcinogens directly damage DNA, creating mutations. Chemical carcinogens like polycyclic aromatic hydrocarbons in tobacco smoke and aflatoxins produced by certain fungi metabolically activate to form DNA-reactive compounds. Radiation, whether ionizing radiation from X-rays and radioactive materials or ultraviolet radiation from sunlight, damages DNA directly through energy transfer. Many carcinogens require metabolic activation by enzymes that normally detoxify foreign compounds, but sometimes inadvertently create more reactive and dangerous metabolites. Other carcinogens work indirectly. Hormones like estrogen promote cell proliferation in responsive tissues, increasing the number of cell divisions, and thus opportunities for mutations to occur and persist. Chronic inflammation, as we've discussed in other contexts, creates a tissue environment rich in reactive oxygen species and growth factors that promote mutation and proliferation. Certain viruses contribute to carcinogenesis through several mechanisms. Some insert their genetic material into host chromosomes, potentially disrupting tumor suppressor genes. Some produce proteins that inactivate P53 or retinoblastoma protein, removing key growth constraints. Some cause chronic inflammation that indirectly promotes cancer development. Metastasis, the spread of cancer cells from primary tumor to distant sites, represents the most lethal aspect of malignancy. The metastatic cascade involves multiple steps, each presenting barriers that most cancer cells fail to overcome. Cells must detach from the primary tumor, invade through surrounding tissue and basement membranes, enter blood vessels or lymphatics, intravasation, survive in circulation despite shear forces and immune attack, exit vessels at distant sites, extravasation, survive in the foreign microenvironment of the new organ, and successfully proliferate to form secondary tumors. The inefficiency of metastasis means that while millions of cells may enter circulation daily from a sizable tumor, few establish successful metastases. Different cancers show preferential patterns of metastatic spread based partly on anatomy and partly on organ-specific factors. Lung cancer commonly metastasizes to brain, bone, liver, and adrenal glands. Breast cancer favors bone, lung, liver, and brain. Prostate cancer has particular affinity for bone. These patterns reflect both the path of blood flow, which carries cancer cells to the first capillary bed encountered, and the compatibility between cancer cells and specific organ microenvironments, the so-called seed and soil hypothesis, where cancer cells, seeds, grow best in congenial organs, soil. The immune system's relationship with cancer proves complex and bidirectional. Immune surveillance, the concept that immune cells continuously monitor for and eliminate malignant cells, provides protection against cancer development. Natural killer cells recognize and kill cells with abnormal surface marker expression. Cytotoxic T cells attack cells presenting tumor-associated antigens. However, tumors that successfully grow have typically evolved mechanisms to evade immune destruction. They may downregulate expression of molecules needed for immune recognition, secrete immunosuppressive factors that inhibit immune cell function, or recruit regulatory T cells and other immunosuppressive cells to the tumor microenvironment. Paradoxically, chronic inflammation can promote rather than prevent cancer development. Inflammatory cells produce reactive oxygen species causing DNA damage and release growth factors stimulating cell proliferation. The inflammatory tumor microenvironment often includes macrophages, lymphocytes, and other immune cells that, rather than eliminating cancer cells, support tumor growth, promote angiogenesis, and facilitate invasion and metastasis. This demonstrates again how biological processes serving protective functions in one context can become harmful when persisting inappropriately or occurring in altered contexts. We shift focus now to examine infectious diseases, where pathology results from interactions between host and pathogen. Infectious agents include viruses, bacteria, fungi, parasites, and prions, each with characteristic structures, life cycles, and mechanisms of causing disease. The outcome of infection depends on a balance between pathogen virulence factors that enable invasion and damage, and host defense mechanisms that attempt to eliminate the invader. Viruses, being obligate intracellular parasites lacking the machinery for independent metabolism or reproduction, must enter host cells to replicate. Different viruses employ varied strategies for cell entry, some binding to specific surface receptors, others fusing their envelope with a cell membrane. Once inside, they commandeer cellular ribosomes to synthesize viral proteins and use cellular resources to replicate their genetic material. Some viruses lyse the host cell upon release, directly causing cell death. Others bud from the cell surface, acquiring an envelope from host membrane and potentially releasing numerous progeny while the host cell survives for a time. Viral infections produce pathology through several mechanisms. Direct cytopathic effects include the cell lysis just mentioned, but also inhibition of host protein synthesis, damage to cell membranes, and formation of inclusion bodies representing aggregated viral proteins or nucleic acids. Indirect effects arise from immune responses to infection. Cytotoxic T cells kill virus-infected cells, an effective antiviral strategy that necessarily destroys infected tissue. Immune complexes formed from viral antigens and antibodies can deposit in tissues, causing type 3 hypersensitivity reactions. Chronic viral infections may trigger autoimmunity through molecular mimicry, where immune responses against viral proteins cross-react with similar host proteins. Some viruses persist in host cells long-term, establishing latent infections that may reactivate. Herpes viruses exemplify this pattern. After primary infection, these viruses establish latency in neurons or lymphocytes, their genomes persisting in an inactive state for years or decades. When host immunity wanes, the virus may reactivate, producing new lesions. Herpes simplex can recur as cold sores or genital lesions. Varicella zoster virus, causing chickenpox during primary infection, may reactivate years later as shingles. Painful dermatomal rash following the distribution of nerves harboring latent virus. Bacterial infections demonstrate extraordinary diversity, reflecting the vast differences among bacterial species in structure, metabolism, and pathogenic mechanisms. Gram-positive and gram-negative bacteria differ in cell wall structure, with implications for antibiotic susceptibility and immune recognition. Some bacteria produce toxins that damage host tissues. Exotoxins, secreted proteins with specific toxic activities, include neurotoxins like those produced by Clostridium tetani and Clostridium botulinum, which interfere with neurotransmitter release, causing tetanic paralysis or flaccid paralysis respectively. Endotoxin, the lipopolysaccharide component of gram-negative bacterial cell walls, triggers intense immune responses when released from bacterial surfaces, potentially causing septic shock through massive cytokine release and widespread vascular dysfunction. Bacteria employ varied virulence factors, facilitating infection. Adhesins allow attachment to host cells or tissues, a prerequisite for establishing infection. Capsules surrounding some bacteria resist phagocytosis, allowing bacterial survival despite immune responses. Some bacteria produce enzymes that degrade host tissue barriers or inactivate antibodies. Intracellular bacteria, like Mycobacterium tuberculosis, survive within macrophages by preventing phagosome-lysosome fusion, protecting themselves from the lysosomal enzymes that would normally destroy them. The body's response to bacterial infection involves innate and adaptive immunity. Complement activation directly kills some bacteria and opsonizes others for phagocytosis. Neutrophils and macrophages engulf and destroy bacteria through oxidative burst and enzymatic digestion. Antibodies facilitate bacterial clearance through opsonization, complement activation, and neutralization of toxins. Cell-mediated immunity proves particularly important for intracellular bacteria, with activated macrophages capable of killing bacteria they harbor, and cytotoxic T cells destroying infected cells. Fungal infections range from superficial skin and nail infections to life-threatening systemic infections in immunocompromised individuals. Most fungi exist as environmental saprophytes, but some can cause disease in humans. Dermatophytes cause athlete's foot, ringworm, and similar superficial infections, their enzymes digesting keratin in skin, hair, or nails. Opportunistic fungi like Candida and Aspergillus rarely cause problems in immunocompetent individuals, but produce severe infections when immunity is compromised by HIV, chemotherapy, or immunosuppressive medications. Dimorphic fungi can cause serious infections even in healthy individuals, existing as molds in soil but transforming to yeast forms when inhaled and encountering body temperature. parasitic infections affect billions of people worldwide, particularly in tropical and subtropical regions. Protozoan parasites like Plasmodium species causing malaria undergo complex life cycles involving mosquito vectors and multiple developmental stages in human liver and red blood cells. Helminth parasites include nematodes, cestodes, and trematodes, worms that may inhabit intestines, blood vessels, or tissues, depending on species. Many parasites have evolved sophisticated mechanisms to evade immune responses, varying their surface antigens, suppressing host immune function, or sequestering themselves in immune-privileged sites. Prions represent an unusual category of infectious agent composed of misfolded protein lacking nucleic acid. The prion protein can induce normal cellular prion proteins to misfold, creating a chain reaction of protein misfolding that accumulates in brain tissue. The resulting spongiform encephalopathies, including Creutzfeldt-Jakob disease in humans and bovine spongiform encephalopathy in cattle, cause progressive neurodegeneration. Prions resist standard sterilization procedures that destroy conventional pathogens, their protein-only nature challenging our usual concepts of infectious agents. Infectious disease outcomes depend heavily on host factors including age, nutritional status, genetic background, and immune competence. The very young and very old show increased susceptibility to many infections due to immature or waning immunity. Malnutrition impairs immune function, particularly cell-mediated immunity. Genetic polymorphisms in immune genes affect susceptibility to specific infections. The most dramatic example of how immunity affects infectious disease outcome comes from HIV/AIDS, where progressive immune destruction transforms normally harmless organisms into life-threatening pathogens. We turn now to nutritional and environmental diseases, where pathology arises from inadequate or excessive nutrients, or from exposure to physical and chemical agents in the environment. The body requires a remarkable array of nutrients for normal function. Macronutrients providing energy and structural building blocks, essential amino acids that cannot be synthesized, essential fatty acids, vitamins serving as enzyme cofactors or fulfilling other specific functions, and minerals participating in numerous physiological processes. Deficiency or excess of any nutrient can produce pathological states. Protein energy malnutrition represents the most widespread nutritional disorder globally. Marasmus, resulting from overall caloric insufficiency, causes wasting of muscle and fat, growth retardation in children, and increased susceptibility to infection. Kwashiorkor, developing when protein intake is particularly inadequate despite some caloric consumption, produces edema from decreased plasma proteins, fatty liver from impaired lipoprotein synthesis, and skin changes. Both forms severely compromise immune function, wound healing, and growth, creating vulnerabilities that extend far beyond the visible wasting. Vitamin deficiencies produce specific syndromes reflecting each vitamin's physiological roles. Vitamin A deficiency impairs vision, particularly night vision, and compromises epithelial integrity in eyes, skin, and respiratory tract. Vitamin D deficiency causes rickets in children and osteomalacia in adults, both characterized by defective bone mineralization from inadequate calcium absorption. Vitamin K deficiency impairs blood clotting through effects on clotting factor synthesis. B vitamin deficiencies affect energy metabolism and nerve function. Thiamine deficiency causes beriberi with cardiac and neurological manifestations. Niacin deficiency causes pellagra with its triad of dermatitis, diarrhea, and dementia, and vitamin B12 deficiency produces pernicious anemia and neurological degeneration. Vitamin C deficiency leads to scurvy, a disorder of collagen synthesis. Without adequate vitamin C serving as cofactor for enzymes that hydroxylate proline and lysine in collagen, the collagen produced lacks stability. Blood vessel walls weaken, causing hemorrhages. Wound healing falters. Bone and cartilage development becomes abnormal. The constellation of bleeding gums, petechiae, poor wound healing, and bone pain reflects the ubiquitous role of collagen in tissue structure. Mineral deficiencies also produce specific pathological states. Iron deficiency, the most common nutritional deficiency worldwide, causes anemia from inadequate hemoglobin synthesis. Red cells become small and pale, their oxygen carrying capacity reduced. Iodine deficiency impairs thyroid hormone synthesis, causing goiter as the thyroid gland enlarges in attempt to compensate, and in severe cases causing cretinism when deficiency occurs during fetal development. Zinc deficiency impairs immune function, wound healing, and growth. Calcium deficiency affects bone density and neuromuscular function. Nutritional excesses create their own pathological consequences. Obesity, characterized by excessive fat accumulation, increases risk for numerous diseases including type 2 diabetes, cardiovascular disease, certain cancers, and osteoarthritis. The mechanisms linking obesity to these conditions include insulin resistance from adipose tissue-derived factors, mechanical stress on joints from increased weight, altered hormone profiles, and chronic low-grade inflammation originating in adipose tissue. Vitamin toxicities can occur, particularly with fat-soluble vitamins that accumulate in tissues. Vitamin A excess causes liver damage and birth defects. Vitamin D excess leads to hypercalcemia with its attendant problems of kidney stones and tissue calcification. Environmental diseases arise from exposure to countless potential hazards in air, water, soil, workplace, and home. Air pollution, particularly fine particulate matter, causes and exacerbates respiratory disease, increases cardiovascular mortality, and likely contributes to other conditions through inflammatory and oxidative stress pathways. Occupational exposures to dusts cause pneumoconiosis, chronic lung diseases named for the inhaled material, silicosis from silica dust, asbestosis from asbestos fibers, coal workers' pneumoconiosis from coal dust. Each produces chronic inflammation and progressive fibrosis that impairs lung function. Heavy metal poisoning demonstrates specific toxic mechanisms. Lead interferes with hemosynthesis, causing anemia, and damages nervous system development in children, producing cognitive impairment. Mercury accumulates in brain tissue, causing neurological dysfunction. Cadmium damages kidney tubules. Arsenic causes skin changes and increases cancer risk. Industrial chemicals like organic solvents damage liver and kidneys. Pesticides affect nervous system function through various mechanisms depending on chemical class. Physical environmental factors cause injury and disease as well. Extremes of temperature produce hypothermia or hyperthermia, each with characteristic pathophysiological consequences. Ionizing radiation damages DNA and other cellular components, with effects ranging from acute radiation sickness after high doses to increased cancer risk from chronic low-level exposure. Ultraviolet radiation from sun exposure causes acute sunburn and long-term increases skin cancer risk. Mechanical trauma from accidents or violence produces injuries ranging from minor to fatal. The skin, Our primary interface with environment deserves particular attention as a barrier that protects against chemical, physical, and biological hazards while also being vulnerable to injury from those same hazards. The stratified squamous epithelium of epidermis creates a physical barrier, while melanocytes produce melanin that absorbs ultraviolet radiation, protecting deeper cells from DNA damage. Langerhans cells in epidermis function as immune sentinels. The dermis provides structural support and contains nerves, blood vessels, and skin appendages. Subcutaneous fat cushions underlying structures. Skin pathology manifests in countless ways, reflecting diverse mechanisms of injury and disease. Inflammatory skin diseases like eczema and psoriasis involve immune dysfunction, producing characteristic patterns of inflammation and epidermal changes. Infections produce lesions ranging from impetigo, a superficial bacterial infection, to deeper cellulitis involving dermis and subcutaneous tissue. Fungal infections affect various skin depths. Skin cancers include basal cell and squamous cell carcinomas arising from epidermal cells and melanoma developing from melanocytes, the latter particularly dangerous due to metastatic potential. Genetic diseases constitute another major category of pathology, where inherited or spontaneous mutations cause disease through diverse mechanisms. Mutations may affect structural proteins, enzymes, receptors, signaling molecules, or regulatory sequences, controlling gene expression. The consequences range from lethal conditions incompatible with life to subtle susceptibilities affecting disease risk later in life. Inheritance patterns depend on whether the mutant gene is autosomal or sex-linked, and whether the mutation is dominant or recessive. Autosomal dominant disorders require only one mutant copy for disease manifestation, with affected individuals typically having an affected parent and 50% chance of transmitting the mutation to each child. These disorders often affect structural proteins where the mutant protein interferes with normal protein function. Familial hypercholesterolemia, with defective LDL receptors causing elevated cholesterol and premature atherosclerosis, exemplifies autosomal dominant inheritance. Autosomal recessive disorders require two mutant copies, one from each parent, for disease manifestation. Carriers with one mutant copy remain clinically normal. Parents are often unaffected carriers, with 25% chance that each child inherits two mutant copies and develops disease. Enzyme deficiencies frequently follow this pattern, since one functional gene copy typically produces enough enzyme for normal function. Cystic fibrosis, phenylketonuria, and sickle cell disease all follow autosomal recessive inheritance. X-linked disorders result from mutations in genes on the X chromosome. Males, having only one X chromosome, develop disease if they inherit a mutant X. Females with two X chromosomes usually remain asymptomatic carriers due to their second normal X chromosome. Hemophilia and Duchenne muscular dystrophy follow X-linked recessive inheritance. The characteristic pattern shows affected males related through carrier females, with no male-to-male transmission. Chromosomal disorders involve abnormalities in chromosome number or structure. Down syndrome, with an extra copy of chromosome 21, produces characteristic facial features, intellectual disability, and increased risk for certain medical problems through mechanisms involving gene dosage imbalance. Turner syndrome, with loss of one sex chromosome in females, causes short stature and ovarian dysgenesis. Chromosomal translocations may disrupt important genes or create fusion genes with abnormal function. many leukemias arising from specific chromosomal translocations. The molecular basis of genetic disease continues expanding as genome sequencing reveals mutations underlying previously unexplained conditions. Some mutations cause loss of function, the gene product being absent or non-functional. Others cause gain of function, the gene product acquiring new inappropriate activities. Some create dominant negative effects, where mutant protein interferes with normal protein produced from the normal gene copy. Understanding molecular mechanisms guides therapeutic development, with treatments aimed at replacing missing gene products, reducing accumulation of toxic metabolites, or correcting the underlying genetic defect through gene therapy. We recognize, as this third phase of our exploration draws toward its close, how these various categories of disease mechanisms interweave. Genetic susceptibilities influence cancer risk, infection outcomes, and responses to environmental exposures. Nutritional status affects immune function and thus infection susceptibility. Environmental carcinogens cause the mutations driving neoplasia. Chronic infections promote inflammation that increases cancer risk. The categories we create for organizational purposes represent artificial boundaries across what is fundamentally an interconnected web of biological processes. Your own genetic heritage influences your vulnerabilities and strengths. Your environmental exposures throughout life accumulate effects subtle and obvious. Your nutritional choices affect current function and future disease risk. And your immune system continuously adapts to the microbial communities you encounter. These processes unfold largely beneath conscious awareness, the body managing countless transactions with its environment, defending against threats, repairing injuries, and maintaining the dynamic stability we call health. In studying pathology, we become conscious of these normally invisible processes, appreciating both their robustness and their vulnerabilities, recognizing that health represents not a static state, but continuous active maintenance of favorable conditions despite unceasing challenges. We arrive at the final portion of our journey through pathology's intricate terrain, carrying with us the understanding we've accumulated of cellular injury and adaptation, inflammation and repair, hemodynamic disturbances, immune dysfunction, neoplasia, infection, and the influences of nutrition, environment, and genetics. Now we draw these threads together, examining how disturbances in specific organ systems manifest the general principles we've explored, how regulatory mechanisms integrate body-wide responses to disease, and how understanding pathology illuminates both the fragility and extraordinary resilience of human biology. The concept of organ system pathology recognizes that while general mechanisms apply universally, each organ possesses unique structural and functional characteristics that shape how disease manifests. The cardiovascular system, responsible for circulating blood throughout the body, demonstrates pathology arising from vessel disease, cardiac dysfunction, or disturbances in blood pressure regulation. Atherosclerosis, the arterial disease underlying most heart attacks and strokes, illustrates how chronic processes accumulate over decades to produce acute catastrophic events. Atherosclerosis begins with endothelial dysfunction, subtle changes in the arterial lining's properties that increase permeability and promote inflammation. Low-density lipoproteins carrying cholesterol enter the arterial wall and become oxidized, chemically modified in ways that make them recognizable as foreign by the immune system. Monocytes recruited into the vessel wall transform into macrophages that ingest oxidized lipoproteins, becoming foam cells laden with lipid droplets. These foam cells accumulate along with smooth muscle cells that migrate from the arterial media, extracellular matrix, and inflammatory mediators, forming atherosclerotic plaques that gradually enlarge and narrow the arterial lumen. The plaque contains a lipid-rich core covered by a fibrous cap. The balance between factors promoting cap stability and those degrading it determines the plaque's vulnerability to rupture. Stable plaques with thick fibrous caps may produce symptoms through gradual luminal narrowing, causing angina when coronary artery narrowing limits blood flow to heart muscle during exertion. Vulnerable plaques with thin caps and large lipid cores are prone to rupture, exposing thrombogenic material that triggers rapid thrombus formation. This acute thrombosis produces the sudden complete vessel occlusion, causing myocardial infarction or ischemic stroke, transforming chronic stable disease into acute life-threatening emergency. The heart itself experiences pathology through various mechanisms. Ischemic heart disease from coronary atherosclerosis represents the most common form of heart disease in developed nations. Myocardial infarction produces a zone of dead cardiac muscle that heals by scarring, reducing the heart's contractile capacity, and potentially causing heart failure if sufficient muscle is lost. Arrhythmias may develop from scar tissue disrupting normal electrical conduction pathways. Complications during the healing phase include ventricular rupture, formation of ventricular aneurysms, and mitral regurgitation if papillary muscles supporting the mitral valve are damaged. Hypertensive heart disease develops when chronically elevated blood pressure forces the heart to work harder to eject blood against increased resistance. The left ventricle undergoes hypertrophy, individual cardiac muscle cells enlarging to generate greater force. Initially compensatory, this hypertrophy eventually becomes maladaptive as the thickened ventricle becomes stiffer, filling less efficiently during diastole. The coronary blood supply, which must penetrate through the thickened muscle, may prove inadequate, causing ischemia even without coronary artery obstruction. Progressive dysfunction leads to heart failure, that state where the heart cannot pump adequate blood to meet the body's metabolic needs. Heart failure produces a cascade of consequences throughout the body. Reduced cardiac output triggers compensatory mechanisms, including sympathetic nervous system activation, which increases heart rate and contractility, while constricting peripheral vessels to maintain blood pressure. The kidneys, detecting reduced perfusion, activate the renin-angiotensin-aldosterone system, promoting salt and water retention to expand blood volume. These compensations initially help maintain adequate circulation, but when sustained, they worsen the underlying problem. Increased blood volume overloads the failing heart. Vasoconstriction increases the work required to pump blood. The heart remodels, dilating and becoming less efficient. Fluid backs up behind the failing chambers, producing pulmonary edema if the left heart fails and peripheral edema if the right heart fails. Valvular heart disease represents another category of cardiac pathology, where disease of the heart valves impairs their function. Stenosis, narrowing of a valve opening, forces blood through a restricted orifice, increasing the pressure work required from the chamber ejecting through the stenotic valve. Regurgitation or insufficiency, incomplete valve closure, allows backward flow during the phase when the valve should be closed, imposing volume work on the chambers that must pump the regurgitated blood again. Both stenosis and regurgitation can lead to ventricular hypertrophy, chamber dilation, and eventually heart failure, through chronic hemodynamic stress. The respiratory system, facilitating gas exchange between air and blood, experiences pathology affecting airways, alveoli, interstitium, or pleura. Obstructive lung diseases impair airflow, particularly during expiration. Chronic bronchitis involves inflammation and mucus hypersecretion in airways. The persistent productive cough reflecting the airway's attempts to clear excessive secretions. Emphysema results from destruction of alveolar walls, reducing elastic recoil and causing airways to collapse during expiration, trapping air and producing the characteristic hyperinflated appearance. Asthma features reversible airway narrowing from bronchial smooth muscle constriction, airway inflammation, and mucus plugging, triggered by allergens, irritants, or other stimuli in susceptible individuals. Restrictive lung diseases reduce lung expansion, decreasing total lung capacity. Pulmonary fibrosis, scarring of lung interstitium from various causes, stiffens the lungs and impairs gas diffusion across thickened alveolar capillary barriers. The work of breathing increases as muscles must generate greater force to expand stiff lungs. As disease progresses, blood oxygen levels fall and respiratory failure may develop. Some restrictive diseases have known causes including occupational dust exposures, certain medications, or autoimmune conditions. Others remain idiopathic despite investigation, reflecting our incomplete understanding of mechanisms initiating progressive fibrosis. Pulmonary infections range from pneumonias filling alveoli with inflammatory exudate to tuberculosis creating granulomatous inflammation with central necrosis, to viral infections producing interstitial inflammation. The lung's extensive surface area exposed to inspired air makes it vulnerable to inhaled pathogens, while its elaborate immune defenses usually prevent infection despite constant microbial exposure. When defenses are overwhelmed or compromised, pneumonia develops, alveoli filling with fluid and inflammatory cells rather than air, impairing gas exchange and producing the cough, fever, and shortness of breath characteristic of pneumonia. The gastrointestinal system demonstrates pathology at every level from mouth to anus, affecting digestion, absorption, motility, and barrier function. Peptic ulcers, breaks in the gastric or duodenal mucosa, typically result from imbalance between aggressive factors like acid and pepsin and defensive factors like mucus and bicarbonate secretion. Helicobacter pylori infection disrupts mucosal defenses while promoting acid secretion, explaining its role in most peptic ulcers. Non-steroidal anti-inflammatory drugs impair prostaglandin synthesis needed for mucus production and mucosal blood flow, creating another mechanism for ulcer formation. Inflammatory bowel diseases, including Crohn's disease and ulcerative colitis, involve chronic immune-mediated intestinal inflammation. Ulcerative colitis affects only the colon, producing continuous inflammation limited to the mucosa, causing bloody diarrhea from ulceration of the inflamed lining. Crohn's disease can affect any part of the gastrointestinal tract, produces discontinuous patches of transmural inflammation extending through the full thickness of the bowel wall, and causes complications including strictures, fistulas, and abscesses. Both conditions feature relapsing and remitting courses, likely resulting from complex interactions between genetic susceptibility, intestinal microbiota, immune dysregulation, and environmental factors. Malabsorption syndromes impair nutrient absorption through various mechanisms. Celiac disease, an immune reaction to gluten proteins in susceptible individuals, damages small intestinal villi, reducing absorptive surface area and causing deficiencies of nutrients normally absorbed in the small intestine. Pancreatic insufficiency from chronic pancreatitis or cystic fibrosis reduces digestive enzyme secretion, leaving nutrients in forms too large for absorption. Bacterial overgrowth in the small intestine causes bacteria to consume nutrients before host absorption occurs. Each mechanism produces similar symptoms of diarrhea, weight loss, and specific nutrient deficiencies, but requires different treatment approaches. The liver, that remarkable metabolic factory performing countless functions including protein synthesis, glucose and lipid metabolism, bile production, and detoxification of drugs and metabolic wastes, experiences diverse pathological processes. Hepatitis, inflammation of the liver, has multiple causes including viral infections, alcohol, drugs, and autoimmune disease. Acute hepatitis produces hepatocyte necrosis and inflammation, manifesting as jaundice when damaged liver cannot adequately process bilirubin and elevated liver enzymes from dying hepatocytes releasing their contents. Most acute viral hepatitis resolves completely, but some progress to chronic hepatitis with persistent inflammation that may lead over years to cirrhosis. Cirrhosis represents end-stage liver disease, regardless of cause, characterized by diffuse fibrosis and regenerative nodules that distort normal hepatic architecture. The fibrosis impedes blood flow through the liver, creating portal hypertension, where blood backs up in the portal venous system. This causes varices, dilated thin-walled vessels in esophagus and elsewhere that may rupture catastrophically. It contributes to ascites, fluid accumulation in the abdominal cavity from increased pressure forcing fluid from vessels and from decreased albumin production, reducing oncotic pressure. It shunts blood around the liver rather than through it, preventing detoxification and allowing toxic metabolites to accumulate, contributing to hepatic encephalopathy, the altered mental state from accumulated toxins affecting brain function. Kidney pathology affects filtration, tubular function, or both. Glomerular diseases impair the filtration barrier, allowing protein and sometimes blood cells to leak into urine. Nephrotic syndrome features massive proteinuria, hypoalbuminemia from urinary protein loss, edema from reduced oncotic pressure, and hyperlipidemia from compensatory hepatic lipoprotein synthesis. Nephritic syndrome presents with hematuria, hypertension, and reduced glomerular filtration rate, reflecting inflammatory glomerular injury with different mechanisms and consequences than nephrotic syndrome. Acute kidney injury represents rapid decline in kidney function from various causes, including ischemia, toxins, or obstruction. Prerenal causes involve reduced blood flow to kidneys from shock or dehydration. Intrinsic renal causes involve direct kidney parenchymal injury, most commonly acute tubular necrosis, where tubular epithelial cells die from ischemia or toxins. Postrenal causes involve obstruction to urine outflow. Each category requires different management, but all can produce similar biochemical abnormalities as kidney function fails, with rising creatinine and blood urea nitrogen levels, electrolyte disturbances, and fluid retention. Chronic kidney disease develops over months to years from sustained kidney injury. Diabetes and hypertension represent the most common causes, producing progressive nephrosclerosis, where glomeruli become sclerotic and non-functional. As functional nephron mass declines, remaining nephrons undergo adaptive hyperfiltration and hypertrophy, initially maintaining adequate filtration, but eventually succumbing to the increased workload with further scarring. The gradual progression allows significant adaptation. with patients sometimes remaining relatively asymptomatic until kidney function has declined markedly. Eventually, dialysis or transplantation becomes necessary when kidney function proves insufficient to maintain life. The nervous system's pathology encompasses diverse mechanisms affecting neurons, supporting cells, or myelin. Cerebrovascular disease, including ischemic and hemorrhagic strokes, represents acute interruption of blood supply to brain regions. Ischemic stroke from thrombosis or embolism produces infarction, with neurons particularly vulnerable to oxygen deprivation dying within minutes. The infarcted tissue undergoes liquefactive necrosis, ultimately leaving a fluid-filled cystic cavity. Surrounding the infarct core exists a penumbra of injured but potentially salvageable tissue, the target for interventions aiming to restore blood flow quickly. Hemorrhagic stroke from ruptured vessels produces mass effect from accumulated blood-compressing brain tissue, direct injury from blood-disrupting tissue architecture, and secondary injury from blood breakdown products and inflammatory responses. Hypertension predisposes to intracerebral hemorrhage by causing degenerative changes in small penetrating arteries. Ruptured aneurysms cause subarachnoid hemorrhage, blood spreading through cerebrospinal fluid spaces around the brain. Neurodegenerative diseases involve progressive loss of specific neuronal populations through mechanisms incompletely understood, but often involving protein misfolding and aggregation. Alzheimer's disease features accumulation of amyloid plaques and neurofibrillary tangles in brain, with progressive neuronal loss particularly affecting hippocampus and cortex, producing the characteristic memory impairment and cognitive decline. Parkinson's disease involves loss of dopaminergic neurons in substantia nigra, with remaining neurons containing Lewy bodies composed of aggregated alpha-synuclein protein, producing tremor, rigidity, and bradykinesia from disrupted motor control circuits. Demyelinating diseases damage the myelin sheath's insulating axons. Multiple sclerosis, an autoimmune condition, produces scattered plaques of demyelination in central nervous system white matter, causing varied neurological symptoms depending on lesion locations. The demyelination slows or blocks nerve conduction, producing weakness, sensory disturbances, visual problems, or other deficits. Some remyelination occurs, explaining the characteristic relapsing-remitting course many patients experience, but repeated demyelination and incomplete remyelination lead to progressive disability. The endocrine system coordinates body functions through hormones, chemical messengers released into bloodstream to affect distant target tissues. Endocrine pathology often involves either hypersecretion or hyposecretion of hormones, with predictable consequences from disrupted feedback loops. Diabetes mellitus exemplifies endocrine disease with widespread consequences. Type 1 diabetes results from autoimmune destruction of insulin-producing pancreatic beta cells, producing absolute insulin deficiency. Type 2 diabetes involves insulin resistance, where target tissues respond inadequately to insulin, combined with relative insulin deficiency as beta cells cannot produce enough insulin to overcome resistance. The metabolic derangements of diabetes extend far beyond elevated blood glucose. Without adequate insulin signaling, cells cannot take up glucose efficiently, relying instead on fatty acid metabolism that produces ketone bodies, potentially leading to diabetic ketoacidosis. Chronic hyperglycemia causes glucose to bind proteins throughout the body in non-enzymatic glycation reactions, forming advanced glycation end products that alter protein function and contribute to diabetic complications. Small vessel disease affects eyes, kidneys, and nerves, producing retinopathy, nephropathy, and neuropathy. Large vessel atherosclerosis accelerates, increasing risk for heart attack and stroke. Understanding diabetes pathogenesis guides treatment strategies targeting different aspects of the disease. Thyroid disorders demonstrate how hormones regulate metabolic rate. Hyperthyroidism from excessive thyroid hormone secretion increases metabolic rate, producing weight loss despite increased appetite, heat intolerance, tachycardia, and anxiety. Graves' disease, the most common cause, involves antibodies that stimulate the thyroid hormone receptor. Hypothyroidism from inadequate hormone production slows metabolism, causing weight gain, cold intolerance, bradycardia, and lethargy. Hashimoto thyroiditis, an autoimmune destruction of thyroid tissue, represents a common cause. The musculoskeletal system experiences pathology affecting bones, joints, or muscles. Osteoporosis involves reduced bone mass and microarchitectural deterioration, increasing fracture risk. The balance between osteoblasts, building bone, and osteoclasts, resorbing bone, normally maintains bone mass in adults. But with aging, particularly after menopause in women when estrogen levels decline, resorption exceeds formation. Genetic factors, nutrition, physical activity, and various hormones influence bone density. Fractures from osteoporosis, particularly of hip, spine, and wrist, cause significant morbidity and mortality, especially in the elderly. Arthritis encompasses numerous conditions, causing joint inflammation or degeneration. Osteoarthritis, the most common form, involves progressive cartilage degradation with secondary bone changes including osteophyte formation at joint margins. Mechanical stress, aging, prior injury, and obesity contribute to cartilage breakdown. The resulting joint pain and stiffness impair mobility and quality of life. Rheumatoid arthritis, an autoimmune disease, produces chronic inflammation of synovial membranes lining joints, with pannus formation gradually eroding cartilage and bone, leading to joint deformity and disability if untreated. As we survey these varied manifestations of pathology across organ systems, certain themes recur. Chronic diseases often involve initial adaptive responses that become maladaptive when sustained. Atherosclerosis begins with endothelial attempts to handle lipid accumulation. Cardiac hypertrophy initially compensates for increased workload. These adaptations eventually contribute to disease progression. Inflammation, beneficial in acute infection or injury, becomes destructive when chronic, driving atherosclerosis, neurodegenerative disease, and numerous other conditions. Fibrosis, representing tissue repair, when regeneration cannot occur, restores continuity but reduces function, whether in heart, lung, liver, or kidney. The body's interconnected nature means that disease in one system propagates to others. Heart failure causes kidney dysfunction from reduced perfusion and venous congestion. Kidney failure causes cardiovascular disease through hypertension, fluid overload, and metabolic disturbances. Liver cirrhosis affects coagulation, metabolism, and immune function. Diabetes damages blood vessels throughout the body. Understanding these interconnections helps predict disease complications and guides comprehensive treatment approaches addressing multiple affected systems. Regulatory mechanisms integrate responses across systems, attempting to maintain homeostasis despite disease. The hypothalamic pituitary adrenal axis responds to stress by increasing cortisol secretion, mobilizing energy reserves, and modulating immune responses. The autonomic nervous system adjusts heart rate, blood pressure, and organ perfusion based on moment-to-moment needs. these regulatory systems themselves can become dysregulated, contributing to disease rather than compensating for it. Chronic stress with sustained cortisol elevation affects metabolism, immune function, and cardiovascular system. Autonomic dysfunction contributes to orthostatic hypotension, arrhythmias, and other problems. The concept of pathophysiology synthesizes anatomy, physiology, and pathology to explain how disease produces clinical manifestations. Why does myocardial infarction cause chest pain? Ischemic cardiac muscle releases substances that stimulate pain receptors. Why does pneumonia cause fever? Bacterial products and immune cell cytokines reset the hypothalamic thermostat. Why does liver failure cause encephalopathy? Accumulated ammonia and other toxins affect brain function. Each symptom reflects specific underlying mechanisms, and understanding those mechanisms allows rational approaches to diagnosis and treatment. Clinical medicine builds upon pathology's foundation, using knowledge of disease mechanisms to interpret findings and guide interventions. Physical examination seeks signs of pathological processes. The cardiac murmur reflecting turbulent flow through diseased valve, the abdominal distension from ascites in liver disease, the neurological deficits from stroke. Laboratory tests quantify markers of organ function and disease, elevated cardiac enzymes from myocyte necrosis, abnormal liver function tests from hepatic injury, rising creatinine from kidney dysfunction. Imaging visualizes pathological changes. The occluded coronary artery on angiography, the lung infiltrate on chest radiograph, the brain infarct on imaging. Treatment strategies emerge from understanding pathogenesis. If a disease results from infection, antimicrobial therapy targeting the pathogen makes sense. If inflammation drives tissue damage, anti-inflammatory or immunosuppressive medications may help. If a hormone is deficient, replacement therapy addresses the deficiency. If thrombosis causes acute ischemia, restoring blood flow through clot dissolution or mechanical removal limits tissue damage. Not all diseases have specific treatments targeting underlying mechanisms, but understanding pathophysiology guides symptomatic management and helps predict disease course. Prevention builds on identifying risk factors and interrupting pathological processes before irreversible damage occurs. Understanding that atherosclerosis develops over decades from modifiable risk factors including hyperlipidemia, hypertension, smoking, and diabetes guides preventive strategies addressing those factors. Recognizing that cervical cancer often follows persistent HPV infection led to development of vaccines preventing infection. Knowing that certain genetic mutations dramatically increase cancer risk allows enhanced screening or prophylactic interventions for affected individuals. The trajectory of medical knowledge involves continuous refinement of our understanding of disease mechanisms. Pathology today looks very different from pathology a century ago, when microscopic examination of tissues could describe structural changes but not explain molecular mechanisms. Modern pathology integrates molecular biology, genetics, immunology, and other disciplines to understand disease at multiple levels, from molecules to cells to tissues to organs to the whole organism. This deeper understanding enables more precise diagnosis and more targeted therapies. Yet, fundamental principles persist across this evolving landscape. Disease represents disturbance of normal structure or function. The body responds to injury with programmed sequences attempting to limit damage and restore homeostasis. Sometimes these responses succeed, sometimes they prove inadequate, and sometimes they themselves become harmful. Understanding these patterns provides framework for approaching any disease, known or newly discovered, familiar or rare. As we draw toward the end of this exploration, we return to where we began, to the recognition that pathology ultimately concerns not isolated processes, but the integrated functioning of a living organism responding to internal and external challenges. Your body at this moment maintains countless equilibria, adjusts to subtle changes, repairs minor damages, and defends against threats, all while you direct your conscious attention elsewhere. The cells replacing themselves, the immune surveillance eliminating abnormal cells, the subtle adjustments in blood flow and hormone levels, the continuous maintenance of barriers and gradients proceed without requiring conscious oversight. This is both reassuring and humbling. Reassuring because the body's robustness and redundancy mean that health persists despite constant perturbations. Humbling because we recognize how much occurs beyond voluntary control, how dependent we are on the proper functioning of systems we cannot directly sense or command. Pathology teaches us about these normally invisible processes by showing us what happens when they falter. But in studying disease, we come to appreciate health, to recognize it not as default state requiring no explanation, but as active achievement maintained through continuous work at every level of biological organization. The language of pathology, with its Greek and Latin roots, its specialized terminology, its careful distinctions between related but distinct processes, represents humanity's attempt to name and understand the disruptions that threaten life and health. Behind the technical vocabulary lie human experiences of illness and suffering, the physicians and scientists who recognized patterns and proposed mechanisms, the patients whose diseases taught lessons that advanced medical knowledge. Every understood mechanism represents questions asked and answered, observations made and interpreted, experiments conducted and analyzed, yet much remains unknown. Despite remarkable advances, many diseases have unclear causes or incompletely understood mechanisms. Treatment remains empirical rather than mechanistic for numerous conditions. The complexity of biological systems, with their countless interactions and feedback loops, their genetic variations among individuals, their responses to environmental factors both recognized and unrecognized, ensures that pathology will continue evolving as research reveals new layers of mechanism and new therapeutic targets. The field moves toward ever more personalized understanding of disease, recognizing that the same diagnosis may represent somewhat different mechanisms in different individuals, influenced by their genetic backgrounds, environmental exposures, microbiomes, and other factors creating individual variation. This precision medicine approach uses detailed molecular characterization of individual patients' diseases to guide treatment selection, choosing therapies most likely to succeed based on specific molecular features rather than broad diagnostic categories alone. Throughout our time together, we've traveled from cellular injury through inflammation and repair, from hemodynamic disorders through immune dysfunction, from neoplasia through infection and nutritional disease, and finally through pathology manifesting in specific organ systems. We've seen common themes emerge: adaptation and its limits, inflammation as double-edged sword, the propagation of disturbances through interconnected systems, the body's attempts to maintain homeostasis despite disease. These themes unite diverse pathological processes into comprehensible patterns. We've also encountered the vocabulary pathology uses to precisely describe observations and communicate findings, recognizing that behind terms like necrosis, metaplasia, dysplasia, and fibrosis lie specific cellular and tissue events with characteristic causes and consequences. This specialized language enables precise communication about complex phenomena, though we remember that the terms themselves are tools for understanding, not the understanding itself. The perspective pathology offers helps situate individual experiences of illness within broader biological context, seeing symptoms not as isolated phenomena, but as manifestations of specific underlying processes that make sense given their mechanisms. This doesn't diminish the personal impact of disease, but rather enriches understanding of what the body experiences and why treatments work or fail based on their effects on disease mechanisms. There is something almost meditative in considering these processes, in recognizing the continuous activity occurring in every body at every moment, the molecular dances in every cell, the immune cells patrolling through blood and tissues, the ongoing synthesis and degradation of proteins, lipids, and carbohydrates, the constant maintenance of gradients and barriers that define life itself. We exist as dynamic processes rather than static objects, our bodies continuously becoming themselves through countless small acts of creation and destruction, damage and repair, challenge and response. As you continue from here, carrying this knowledge forward, you may notice differently the symptoms and signs that arise in yourself and others, recognizing in them the underlying mechanisms we've discussed, seeing not just isolated discomforts, but the body's attempts to signal, to defend, to repair. You may approach health recommendations with different understanding, seeing how they aim to interrupt pathological processes or support healthy ones. You may find that this knowledge, rather than creating anxiety about all that can go wrong, creates appreciation for how much goes right, how robust these systems prove despite their complexity. The study of pathology serves many purposes. It enables diagnosis and guides treatment in clinical medicine. It advances research by identifying questions worth investigating. It satisfies intellectual curiosity about how biological systems work and fail. But perhaps most fundamentally, it connects us to our own biology, helping us understand what we are as living organisms, how we persist in the face of constant challenges, and what it means for these remarkable assemblages of molecules and cells and tissues and organs to maintain themselves as coherent wholes capable of thought and action and experience. In the quiet truth of this moment, processes we've discussed continue throughout your body. Cells damaged by normal metabolism undergo apoptosis and are quietly replaced. Immune cells identify and eliminate abnormal cells before they become problematic. Minor injuries to blood vessel walls get repaired before developing into atherosclerotic plaques. Inflammatory responses resolve after addressing small insults. The whole beautiful, intricate, interconnected system continues its work, maintaining the narrow ranges within which life flourishes, adapting to challenges, defending against threats, existing in that dynamic equilibrium called health. There is profound reassurance in recognizing this constancy, this continuous work occurring beneath awareness, sustaining the possibility of every conscious moment. Rest in that knowledge, in the certainty that you are held by systems refined through billions of years of evolution, supported by mechanisms both robust and delicate, carried forward by the quiet wisdom of biology itself.
you.